It's my great pleasure that we're joined today with Dr. Carl Lloyd. He's a GP and senior researcher, and he has just completed and published a very interesting study on uncomplicated urinary tract infections. So it's my pleasure to turn the floor to you, Carl, to share your presentation. Thank you.
Okay, thank you, Christine. An honor to present the results of this randomized clinical trial. First of all, let me go through the technical issues and to share my screen. Can you see my screen now?
Perfectly. Thank you.
Okay, great. So, this is called the SCOUT study. I would like to, it's a 20-minute presentation. I'd like to have your questions, and the more you ask, the better, for a better understanding of this great deal of work that started in 2020 when we applied for a grant for the Spanish Institute of Health in an application for independent randomized clinical trials. The SCOUT study was performed in 4 areas in Spain. You can see here the different places where this study was carried out, and it was published last Monday in Lancet. The thing, I'm going to talk about the rationale of this study, why we did this study. And the rationale of that is that if we go for first-line antibiotic courses for UTIs across different countries, we see that there is a similar pattern in some of these antibiotics. Obviously, there are some specific antibiotics in the different countries, but if we focus on the European perspective, we can see that some of these antibiotics are the same. For example, last week when we presented this study during the conference, the European Congress in Infectious Diseases and Clinical Microbiology in Munich, in Germany, we can see, for example, they have the single dose 3-gram phosphomycin as one of the first-line therapies. We see the nitrofurantoin 7 days there with a low dose, 50 milligrams 4 times a day. They also have the other salt of nitrofurantoin that can be microcrystals that can be given 100 milligrams twice daily for 5 days. And they also have pivmecillinam 400 milligrams 3 times a day for 3 days. So this pattern is repeated in different countries. In the Spanish context, we consider this single dose phosphomycin and this nitrofurantoin course 50 to 100 milligrams during 5-7 days. We can also see in other countries the recommendation of giving nitrofurantoin for 3 days, but there is no, it's not evidence-based because there are no studies confirming that 3 days is enough for this antibiotic. But anyway, we can see this pattern. By the time this study was planned, we performed a questionnaire-based survey among GPs in Spain, asking them about the antibiotics that they give for urinary tract infections. And one of the questions, one of the main results with more than 1,000 GPs survey is many claim that a single dose fosfomycin was not enough and to cure the infection. And most of them, they said that they prefer using 2 doses of fosfomycin instead of 1. And then that's the reason why we perform this randomized clinical trial, assigning the patients to one of these groups. 1 single dose of fosfomycin, 2 doses of fosfomycin, talking about fosfomycin trometamol, this salt that can be given for 1 day, 2 days. Nitrofurantoin, 100 milligrams for every 8 hours for 5 days, and pivmecillinam, 400 milligrams every 8 hours for 3 days. And why did we consider these doses and these intervals and these durations? Because it was based on most of the studies performed with these different antibiotics. So this is a randomized clinical trial, pragmatic, primary care study, and we followed these patients for 1 month. The main objective was to evaluate the clinical effectiveness of the 4 medications arms at day 7, and we consider clinical resolution when patients reported being cured at day 7. It means disappearance of all the UTI symptoms. And for this talk, we consider the secondary objectives, evaluating the clinical effectiveness, days 14, 28, bacteriological eradication at days 14 and 28, to determine the proportion of patients presenting relapse of symptoms within the first month, patients with severe adverse events or adverse events in general, and to determine the number of patients who require additional antibiotic therapy. We included women of 18 years of age or elder with one of the clinical features of uncomplicated community-acquired lower urinary tract infection, dysuria, urgency, frequency, suprapubic tenderness. And it was a requirement as well, a urine dipstick analysis positive for either nitrites or leukocyte esterase. Women who stick to the 3 criteria were included in the study. Obviously, we excluded patients with severe infection, requiring hospital admission, etc. Upper urinary tract infection, suspicion of acute pyelonephritis. Risk factors for complicated UTIs, such as indwelling catheter, or, for example, recurrent UTIs, more than 3 in the previous year. Long-term prophylactic therapy, these patients were excluded as well. Recent UTI in the previous month. Drug-related contraindications such as hypersensitivity to any of these antibiotics, allergies, etc. Pregnancy and breastfeeding women were also excluded from this study. Follow-up visit. We had these 4 visits, the baseline visit. Each patient was given a symptom diary. They had to implement every day for the first week, and they returned the symptom diaries on day 14. Day 7, they were called for the primary outcome assessment, And on day 14 and 28, patients had to come to the primary care center again. Urine sample was provided at the baseline visit, the first follow-up visit on day 14, and the final visit on day 28. The sample size calculation was, in fact, we consider this clinically important minimum difference of 10%. And this is something that we didn't invent because it's based on this guideline on the evaluation of medicinal products indicated for treatment of bacterial infections issued by the European Medicines Agency in 2022. We assume a clinical efficacy of 75% for the single dose of fosfomycin. And this was based on different studies performed the last decade. But in 2022, there was a systematic review published by Conwar. And they said the same, that the clinical efficacy of fosfomycin was 75%. They included a study published in JAMA in 2018 by Hudner and collaborators. And she was the first admitting that the efficacy of fosfomycin in a single dose was lower than 75%. And she was talking about 57% of efficacy, but it was only one study. So considering all the studies together, the pool efficacy was 75%, also in 2022. Obviously, we consider the type error of 5%, power of 80%. It means a total of 1,120 patients in total. But the funding was terminated in 2024. We managed to include 804 patients with the exclusions you can see in the slide. It means 768 patients randomly assigned to each of the study treatments. Single dose of fosfomycin, 2 doses of fosfomycin, nitrofurantoin for 5 days, and pivmecillinam for 3 days. Patients were instructed to take the antibiotics according to the pharmacokinetics. Patients assigned to the groups of fosfomycin were asked to take the antibiotic on empty stomach or 2 hours after the meal. You can see here that 720 patients were included in the primary analysis. So I think that the loss of patients here was very low. And patients included in the ITT population and safety analysis were the first 768. But for the primary analysis, we considered these 720 patients. These are the baseline characteristics took from the publication. You can see the mean age of the patients was 48 years. Slight differences across the groups. The most common symptom was frequency, followed by dysuria. And one of the striking features of this study was the confirmed UTI. And we're talking about the microbiological confirmed urinary tract infections, was seen in 58% of the cases, with 12-13% of contaminated samples and 30% of negative cultures. You know that these data are consistent with primary care studies. We include patients who have no true UTI. The most common germ, as expected, was E. coli, 72% of the cases, followed by these other germs. The proportion of strains resistant to the allocated antibiotic range from 10% to 16% in the case of pivmecillinam, and the proportion of E. coli strains resistant to the antibiotic range from 0% in the nitrofurantoin group to 8% in the group of patients assigned to pivmecillinam. These are the main results. And the main results here on day 7, clinical resolution. The most effective treatment was nitrofurantoin, 74%, followed by pivmecillinam, 70%, 2 doses of fosfomycin, 67%, whereas the least effective antibiotic was the single dose fosfomycin with 59%. So the difference between the first and the last is 15%, 15 percentile points, favoring nitrofurantoin. We see similar results at day 14 and day 28, but I would like to draw your attention to the patients with a positive urine culture, because among these patients, the effectiveness of nitrofurantoin was much higher, and we're talking about 87%, followed by pivmecillinam, 2 doses of fosfomycin, and the least effective antibiotic again was the single dose of fosfomycin. But if we can compare the difference between nitrofurantoin and the single dose of fosfomycin, we're talking here about 35 percentile points, also favoring nitrofurantoin. So this is a huge difference. And the thing is that it didn't reach the sample size scheduled, but the thing is that we saw these striking differences among the different treatments. And we can say that despite the fact that we didn't reach this 80% of power, in the end, the sample size included in this study yielded a power of 67%, but we managed to get these significant differences among the different groups. And you can see these pairwise comparisons of efficacy outcomes. And in bold, all these differences which were statistically significant. Again, the clinical response on day 7, nitrofurantoin versus the single dose of fosfomycin. All the antibiotics compared to the single dose of fosfomycin. Pivmecillinam was more effective than the single dose of fosfomycin among women with positive urine culture, but also the clinical response on day 14 and day 28 were significantly higher in the group of women assigned to the nitrofurantoin therapy. The bacterial eradication was similar among groups, but the main focus of this study was the clinical effectiveness. And one of the questions is how the age groups perform in terms of the clinical effectiveness was very similar between premenopausal women compared to postmenopausal women. And we see practically the same results when comparing the single dose of fosfomycin with the other 3 short-term antibiotic courses. Additional use of antibiotics for UTIs, you can see that was much higher in the 2 groups of fosfomycin compared to the other 2 groups. nitrofurantoin and pivmecillinam, 30% of the patients who are taking fosfomycin need another antibiotic to get their infection cured. It's a high percentage, and this has to be considered from a clinical point of view, because in the end, these patients are taking 2 antibiotics. Adverse events were very similar across groups. We consider the acute pyelonephritis as one of a special adverse event of interest, and we saw only 4 pyelonephritis. They were cured, and they didn't need hospital admission. Most of the side effects were mild, and one of the questions from a pharmaceutical point of view is the adverse events we can see with the 5-day course of nitrofurantoin. We saw more diarrhea, obviously, in the groups of patients assigned to fosfomycin, because this is all these antibiotics have been used for more than 40 years in many countries. So we clearly know the safety of this, the safety status of all these antibiotics. We know what they cause, and diarrhea in the fosfomycin group, abdominal pain and nausea in the group of patients assigned to nitrofurantoin, headache and nausea, and also diarrhea in the group assigned to pivmecillinam. And the question is, why about these results? Why we didn't expect in fact, these results. These are the latest resistance rates published by the BINCAT in Catalonia. In Catalonia was the area where most women were included in this study. And if we go for the E. coli and resistance in 2024 to fosfomycin and nitrofurantoin, we can say that the resistance are very low. Obviously, it's lower towards nitrofurantoin, because nitrofurantoin is not a common use antibiotic for uncomplicated UTIs. It's given, but not as much as fosfomycin. Considering that both antibiotics are considered first line antibacterial therapies in these patients, but the percentage of strains of E. coli resistant to fosfomycin is lower than 4%, as you can see here. So what are the possible explanations about this? First of all, we have to talk about pharmacokinetics and pharmacodynamics characteristics of the different antibiotics. But I want to talk more about the differences between the single dose fosfomycin and nitrofurantoin. And we know that exposure to nitrofurantoin is more persistent, because we're given a nitrofurantoin for 5 days with a high dose, because 100 milligrams is a high dose. And that's true, because some countries use 50 milligrams, for example, every 8 hours. But we use 100 based on the medical evidence. The concentrations above the minimum inhibitory concentration obviously is much higher for nitrofurantoin rather than fosfomycin. Fosfomycin reaches a peak, but it drops dramatically after this peak, and that's the reason why the concentrations of fosfomycin in urine above the MIC is lower compared to nitrofurantoin. The duration of exposure, obviously, and that might explain why 2 doses of fosfomycin perform much better than only 1. Another issue, and I think it's a very important thing, it's the bacterial load. And when we're talking about the bacterial load of the infections, it means that some women have really true infections, we know that we consider UTI from a microbiological point of view when there are more than 1,000 units per milliliter. But some women have very high count UTIs, more than 10 to the fifth. More than 10 to the fifth, that it was the first definition of UTIs 20 years ago, 30 years ago, when CAS published this study when we consider a patient has a UTI, more than 10 to the fifth. But nowadays, we consider infection more than 10 to the third. And there are differences. I'm going to talk this later about this topic. Another issue is the site of infection, and we know that some women have an early upper tract involvement with these intracellular bacterial reservoirs, where we can see the E. coli in these epithelial cells in the bladder. And we know that nitrofurantoin has a better activity in the bladder tissue compared to fosfomycin. And this is something that we should also consider when given these antibiotics. And the other one is the urine pH. And there are some studies that have shown that when the pH of the urine is low, it's acid, the effectiveness of fosfomycin is lower. And this is a very interesting observation, but we knew about this after the inception of the study. So we didn't consider the pH of the urine in this study, and we don't have information from the patients included in this study. So the thing is that from a clinical point of view, I'm a GP, and as a GP, I'm always asking, what's the resistant rate of E. coli to these antibiotics? It's very low, so we can use any of these antibiotics. That's not true. And we have to reach out to the GPs and say, resistance is important, but it's not the only thing we have to consider when administering an antibiotic. And this is the traditional gap we see between the resistance rates and the real world outcome results. And this is something we have to consider. But let me go back to the bacterial load. This is a post-hoc analysis, and this is something that we want to delve into. And because you can see in the blue bar is the clinical effectiveness. We're talking about the clinical resolution at day 7. This is for all the patients, fosfomycin the least effective, 2 doses of fosfomycin, nitrofurantoin, pivmecillinam in all the patients. The green bar depicts those with a positive culture, microbiologically confirmed UTIs in this study, and the differences here are much higher as mentioned before. Low count, it means 10 to the third to 10 to the fifth colonies per milliliter, and we see that all the antibiotics, fosfomycin is, well, the least effective, but 2 doses is great. Nitrofurantoin is also, the best one. Pivmecillinam also, it's a good antibiotic. But let's go for those with 10 to the fifth or more. And here, fosfomycin drops. So fosfomycin, the effectiveness, the clinical resolution when we give fosfomycin single dose in these patients is lower than 50%. Women assigned to doses perform better. Nitrofurantoin, the best antibiotic also for these high count urinary tract infections. But something occurred with pivmecillinam because there is a drop of 20% of effectiveness comparing low count urinary tract infections with high count infections, something that should be explored further in future studies. But this is something that it's a postdoc analysis, and we want to publish this as a secondary study accompanying this randomized clinical trial. So these are the conclusions of the study. The sample size was not breached, but we managed to get this clinically meaningful differences, and in some cases, statistical differences. The single dose fosfomycin was the least effective antibiotic, while nitrofurantoin was the most effective regimen for women with uncomplicated UTIs. The difference was even greater among women with positive urine cultures. More patients assigned to the fosfomycin groups require additional antibiotics, 30% of the patients. Similar proportion of adverse events among the different women. There was a high rate of negative uncontaminated urine culture, but this is something that maybe we should consider another definition of UTI in future studies. And important issues that the resistant rates alone are insufficient among criteria when selecting an antibiotic. And I think, and that's my opinion, and I'm very independent, that the guidelines should be updated. And in my perspective, single-dose fosfomycin should no longer be recommended as first-line antibiotic for urinary tract infections. I think I have to say that that's an independent, non-industry funded randomized clinical trial. I have no conflicts of interest in this study. And I'll be very happy to take any question you have. And thank you for your attention.
Thank you, Dr. Yor. That was excellent. Questions are already coming in. So the first question says, many thanks for these data and your excellent presentation on this common condition. I'm very happy to hear the effectiveness of nitrofurantoin. This is first line for cystitis in Ireland. Can I ask you to comment on the generalizability to other jurisdictions where historic prescribing patterns and resistant profiles may be different to those in Spain?
Yeah, that's a very good question. But there are no huge differences in terms of resistant rates in Europe. And for example, we saw this 8% of resistance to pivmecillinam in Spain, but we have never used pivmecillinam, and I know that pivmecillinam is frequently used in Scandinavian countries, but the resistant patterns in the different countries are not very different across countries in Europe. But obviously, we have to consider these resistant rates as well. I agree with that, but we don't see these different resistant patterns here. So I think the results are very general. We can generalize, and extrapolate to other realities in Europe, at least in Europe.
Wonderful. I see Maria has a question. Go ahead, Maria.
Yes, thank you so much. Very interesting to listen to, and such an important study because this patient group is huge. And sometimes hard to get a grip on. I'm just thinking about that usually the proportion of E. coli is considered higher than it was in your study. And do you interpret the negative cultures as low amount of uropathological E. coli, or would you consider adding PCR? Maybe
Good
not
question.
in primary diagnosis, but in a study,
No.
just to see.
Yeah, but the thing it's a primary care study, and we're expecting at least 75% of strains of E. coli in our study, but we got the 72%, so it's not much different from what we expected, indeed. It's a primary care study, so using other I would say other diagnostic tools here, I think is not a good strategy from my point of view. And the thing we use the urine cultures for this study, but it's not something that GPs do at the baseline visit in patients with uncomplicated UTIs.
No, you don't culture at all.
Yeah, of course. And the thing is that I think we can generalize the results perfectly to all the realities in primary care. So, but it's certain that we expected a higher amount of E. coli infections. The percentage of positive urine cultures ranges in the middle of the different primary care studies I have seen in uncomplicated UTIs. We participated in other studies with 38% of positive urine cultures, and this is very low. But for example, in Hadner's study, she saw more than 60% of positive cultures. So this 57% of urine cultures is in the middle of all these primary care studies. So I don't think it's a big issue, but this is what happens when we consider only one of the UTI symptoms I mentioned before. Some experts are considering that we should include patients with two or more of the symptoms. This would increase the number of positive cultures for sure. And maybe this is what we should do in future studies. But the thing is that this is a pragmatic study. And we know that GPs consider UTI when the patient has at least one of these symptoms. So we try to replicate what GPs are doing right now, more than what experts consider when a UTI should be considered. No, and we try to perform a pragmatic study, primary care.
Thank you.
Wonderful. Uta.
Yes, sorry, I'm here. Can you hear me?
Yes.
Yeah, super. Thanks, Carl. That was really interesting. I want to pick up on what Maria just asked you about, because I was wondering about your case definition as well. And now that you say, looking into symptoms as defining a UTI, would you then prioritize among the symptoms? Let's say there would be like key symptoms, and then there would be, associated symptoms. And the other thing which kind of belongs to it is you talked about the bacteriological cure. So, I mean, you did some culturing, at least in this case, and found bacteriological cure afterwards. But did you look into relapse and how that, how did symptoms develop? And maybe you said it, maybe I just missed it, but that would be interesting to hear.
Yeah, the thing is that patients assigned to the fosfomycin groups had more relapses, and they took other antibiotics, and then these patients were excluded from this microbiological analysis on day 14. And that's the reason why we didn't see differences, because these patients were taking another antibiotic. So the thing is that we primarily focus on the clinical effectiveness, and we saw 30% of the patients assigned to the fosfomycin groups taking other antibiotics in the first days, no? Because they relapsed and they were not clinically cured. So that's the limitation of the microbiological analysis in this study, because we didn't consider these patients who relapsed.
Yes, and then linked to that, because you had a very nice figure looking into premenopausal and postmenopausal women, and you have the age average of 48, I think.
Yes.
Yeah, so there could be differences between those, and then I'm coming back to your bacteriological cure, because maybe the postmenopausal women will not be bacteriologically cured, but cured. So that could be interesting to look into as well, couldn't it?
Yeah, absolutely. And we did this analysis because this is a question many GPs have when they are visiting an old woman with uncomplicated UTI, and because they consider, well, maybe a single dose of fosfomycin is not enough, no? And we're going for a short-term antibiotic course in these patients. But this is something that we should consider as well. And regarding the predictive symptoms, we're going to study, what are the prediction of having combinations of symptoms, which is the most associated symptom with a microbiological confirmed UTI. So there is a lot of stuff to look into now, and we want to know when a woman is likely to have a UTI based on the clinical symptoms. Yeah.
Great. We've got a couple of questions in the chat as well. Another one is, do you think the clinical selection criteria overdiagnosed UTI, considering the percentage of positive culture confirmed?
Well, the answer is yes, obviously. The thing is that we have to redefine. We have to redefine, because we cannot treat 40% of negative cultures. This is overdiagnosis. This is overdiagnosis clearly, and we have to go for another definition of UTI. And we're treating 40% of patients with, and maybe because I have seen the chat here, and I know some of you, some studies that have used symptomatic treatment, mainly for those patients with a low count UTI, and maybe there are some women that who could be cured without antibiotic treatment, and the publication of these studies comparing symptomatic treatment with antibiotics in suspected uncomplicated UTIs is can shed some light on that, no? And the thing is that some women, considering the definition we consider in this study, could have been cured without antibiotics. And that's true. We have to go for a new definition of UTIs based on these predictive symptoms, for sure.
Okay, thank you. Next question in the chat is, why have you not analyzed microbiological response at day 7?
Yeah, that's a good question, and we consider that. Well, when the study was already initiated, and we didn't see any study with microbiological analysis on day 7. This is the main reason why we consider day 14. But now that the study has been finished, we have seen these results. We missed really not having done this analysis on day 7, because it's a limitation of the study. I agree with the question. Very good question.
Okay, next question is
sorry, Christine.
Yeah, go ahead.
Yes, because it was my question. Thank you, Carlos, because I was very interested in your study. It's a very great study, and I had some doubts about these results, because we have the results at day 14 and 28. And then a second question related to this one is, what do you think about the we don't have statistical differences at day 14 or 28 about bacterial eradication? And then what do you think about this? Because we are talking about the symptomatic resolution. And this is my second question, is the next one about patients taking non-steroidal
Yes.
Is the reason you was talking about now, people who can be treated without antibiotics. And then related with this, do you think that this can be a question to have into account when considering these results, mainly for the secondary studies you are making now, understood? I don't know if you are considering to publish the concomitant treatments with non-steroidal anti-inflammatory steroid drugs.
Yeah. Well, let me answer everything.
Sorry.
Otherwise, I'm going to forget. I'm going to forget these questions. Regarding clinical response on day 14 and 28, this is the slide. We can see significant differences between nitrofurantoin and single dose of azithromycin, as you can see. The microbiological eradication on day 14 and we didn't see differences because of what I said before. More patients in the fosfomycin group other antibiotics, and as soon as they were taking other antibiotics, these patients were excluded from this analysis, from this microbiological analysis, and that's why we didn't see differences in terms of bacteriological eradication. And this is the main explanation. There is no a perfect randomized clinical trial. And first of all, because this is an open level randomized clinical trial, but the results are in line with what we suspected, but not as much as we consider at the very beginning. But the thing is that the results are supported by something that is very objective. It's the number of the percentage of positive urine cultures, because the results among women with positive urine cultures was the same or even greater, as you can see, because with these patients, the second row on the slide, in this slide, is that not only nitrofurantoin was statistically more effective than single dose azithromycin, also pivmecillinam. And we can also see that 2 doses of azithromycin are much better than a single dose. The thing is that we should have considered a fifth group. We should have considered a fifth group. A fifth group with non-steroidal anti-inflammatory drugs. But the sample size would have gone very high, and we never know. We never know what would have happened here. No, but the thing is that I fully agree with the question. We should have considered a placebo group with ibuprofen, diclofenac, whatever. But I agree.
Yes. So maybe we can go over to Jorge now. Jorge, if you would like to, you've got your hand raised. I'm not sure if you are still there. Nope. Jorge? Okay, what about Ronnie then? Go ahead.
So thank you for a very good study. I know it's very difficult to do randomized trials in a messy primary care situation. So you have done really well. I just have a question on the slide that is up on the screen. In the upper right corner, it seems clinical response on day 7, pivmecillinam versus single dose fosfomycin. It looks like the zero is not embraced by the confidence interval. And then I assume, shouldn't that be bolded as being statistically significant?
It was not statistically significant, but nearly significant was, but it wasn't. But we can see in the positive urine cultures was totally significant. So.
Okay, and how come that the zero isn't embraced? I mean, in that case, the lower confidence interval should be below 0.
Yeah, I know it. This analysis was done by an expert statistician. When I saw these confidence intervals, I had the same question, but he said no. There is no significant differences, so I didn't go further with that. But I agree with you. But no statistical differences. No, I can tell you.
Okay, thank you.
Okay, I'm just going to take over the screen for a second and to go through just a couple very quick slides. I know there's some additional questions, but I want to, before people start signing off, I want to, if I can get this, to show just these very brief slides. So in EU-JAMRAI, we are working on strengthening access to all generic antibiotics. So if you would like to work with us, if you would like to have assistance gaining access to nitrofurantoin or pivmecillinam, please send me an email. Here is my email. We are working with the generous funding from the European Commission, trying to strengthen access to these older effective antibiotics. So if that's something that you would like to work with us on, or if you see a need in your country, please don't hesitate to reach out to us. And I just wanted to point out as well, as Dr. Yor said, that we've been using pivmecillinam for decades in Scandinavia. And it's interesting to point out in this study that even though we've been using it for decades, the conclusion of this study found that pivmecillinam is an example of an antibiotic which easily develops resistance in vitro, but apparently can be used broadly in primary care without increase in resistance rates. So in case that you're interested in that. And then I will put up the Menti. We would love to hear your feedback, but I think there are still a couple questions for Dr. Yor. So Ute, go ahead.
No, that's okay. That's okay. Just let's do the Menti.
Yeah, well, people can do it while you ask. I think that's okay.
I'll turn back on my camera. No, I actually wanted to also bring in some ideas and thinking about pivmecillinam. since we do have quite some experience from Scandinavia using it. And it was maybe primarily a comment to what you said, Roar, about the resistance levels to pivmecillinam. We know from UCAS that it is quite difficult to do phenotypic testing. So although we sometimes find relatively high resistance levels, and 8 is not high, but in some countries they're higher, we know from clinical experience that they typically will be overcome by the dosing of 400 milligrams times 3. And probably there's a flaw, or it's difficult to test simply. And that also applies if you use semi-automated systems. It's the same thing. Pivmecillinam is really, really difficult to test for. But we know from clinical experience that it works quite well. So that was just an input in regards to the microbiology part.
Yeah, and when we started the study, we saw some studies comparing 200 every 8 hours with 400 every 8 hours, and we went for the 400 because of the more effectiveness and patients with uncomplicated UTIs. So we went for the most common dose and course for the different antibiotics. I know that you can also use this antibiotic for 5 days, but we went for the 3 days because it was in terms of effectiveness, it was similar. So we went for the 3 days in this study.
Great, thank you. I'll hand over to, I think it's, well, can't see the name, but go on, please.
Yeah, I can't see either. So whoever has their hand raised, go ahead.
Hello, I'm Jorge Rojas. I had just some technical problems earlier. Well, just thank you very much for the great presentation and congratulations for the study. My question is, well, just for you or for if someone knows why it's so limited, the availability of pivmecillinam in so many countries, which with all the AMR problem, I think it's a great source. And another comment that I wanted to say is, yeah, I don't know how much weighted the fact not that the nitrofurantoin was for 5 days, pivmecillinam for 3, fosfomycin was in 2 doses, and that was totally correlated with the clinically efficacy. I don't know how much that kind of duration or day of exposure, like placebo effect, weighted. I know there is nothing to do about it, but yes, it would be interesting to know. And thank you.
Yeah, I agree with you, and this is also something that we are claiming to have pivmecillinam in all the countries. I know that it is accepted, and in the case of Spain, is accepted by the Spanish Agency of Medicinal Products and Drugs, but it's not marketed. So the thing is, why it's not marketed? No, why cannot be used? And yes, because the thing is that if we can no longer use single dose of fosfomycin, and I think we shouldn't do that in the future, we need antibiotics. We need more antibiotics for UTIs. First of all, we have to better diagnose the UTIs. And this is a question, recurrent question here. And the second thing is that we need more antibiotics for treating UTIs. And pivmecillinam should be available everywhere. And that's true. We have to explore. Yeah.
I could just add that's absolutely what we're trying to do in EU-JAMRAI, and that's why we're so thrilled to have this presentation, because nitrofurantoin and pivmecillinam should be available in countries. So we're trying to, they're both older antibiotics, so they have individual hurdles, but we are trying to work with that. And it's really important that we take and use the generic products that are available. Pivmecillinam was approved in the US 2 years ago as a with intellectual property rights, and it costs significantly more than the version that we have available in Europe. So we really want to make sure that we keep that generic version of pivmecillinam. Sorry to interrupt.
Yeah, no. Yeah, totally agree. Totally agree because we need more. And that's true. About the different exposures, well, these are the short-term antibiotics used for uncomplicated UTIs, and that's the main reason why we couldn't double-blind this study, because different exposures, different doses, different. It was quite difficult, but these are the recommendations.
Are there any other unanswered questions in the chat? I can't see the chat right now. If anyone has a last question, I guess, Ronnie.
Not directly a question, but just mentioning that this high quality study clarifies the situation for women with lower UTI, and there are no randomized control trials for men with a lower UTI, but there is a few reasonably good retrospective observational studies, and I linked in one of them in the chat, and that study pretty much comes to the same, a very similar conclusion to yours.
Yeah, that's a good point. That's a good point. Very nice comment. Yeah.
Well, then with that, I'd say thank you so much, Dr. Jord. Thank you to everyone. I think this has been a really productive conversation. We really appreciate that you took time out of your day to join us for this. We will make this recording available as well. And have a nice day. Thank you very much.